Well, good afternoon, everyone. I've thoroughly enjoyed the morning, and what I should tell you straight off is that I'm actually from one of the other HeRCs. So I'm one of the other three fantasy environments that has its own story, its own life, its own expectation, and the question about how we will work together. Hopefully, in a way, a little hint of that will come through this talk, but Ian hasn't asked me to come and speak about another HeRC. That's not what I'm here for. What I'm actually here to do is to give a European perspective, but it happens to have a rather nice link with Ian, and I'll tell you about that in a moment or two. Let's just start with a sort of 40,000-foot view. We tend to think of health information being captured when a citizen engages at a point of care. And if you like, the historic role of the electronic health record has been to enable that to flourish and then the downstream reuse of that information for longitudinal care. We're increasingly, though, being challenged to remember the citizen isn't only a customer of healthcare, but is engaging in rich interactions in wellness, complementary health, social care, and all sorts of pockets like health and like occupation and school health that don't connect with us. As you know, we really want to reuse that information for things like disease registries, screening, recall, and public health. And certainly, as you've heard all morning, we want to reuse this information for research, for teaching, whether it's for clinical trials in a consented format or an unconsented population health basis. It all amounts to nothing unless we do what these two arrows are saying. We have to feed back knowledge from the research side, from the public health side, to make an impact on care delivery. Otherwise, it's just a flurry of papers and data sets and pretty graphs and charts. No offense to those we've seen, but in the end, they've got to go back to where individuals are trying to deliver better and better healthcare. And that's the exciting thing for me about e-health and about what we're trying to do at a European level. As you know, in order for us to do that and to bring richness to the table, we have to integrate a very diverse number of data sources, some of which are novel, some of which are not currently mainstream, like environmental data, and some of which are more about exploiting the data and giving rapid feedback, such as decision support and alerts. And what I want to talk about now briefly is three major areas of challenge that I think unite my group, Ian's group, but unite all of us in the HeRCs. The first one is about putting the patient at the center of care. Another one is about integrating information and interoperability. And then I'm going to talk about two projects that are relating to the discovery of new knowledge. And I'm basically going to talk you through very briefly 4 European projects in which both Manchester and UCL are partners, and we're working together on them. So this is actually a glue story, if I could call it that. Why is it important to put the patient at the center of care? Firstly, and I think the first 3 bullets with numbers in them, I won't read them out, they tell you that actually we can't afford to carry on doing healthcare the way we do. It's too expensive, and it's not necessarily resulting in the best clinical outcomes. And then at the bottom, you've got 3 rather tantalizing bullets. They're admittedly not large studies, but they are suggesting that if we do use ways of communicating, e-health solutions to connect the patient more richly into healthcare, we can make a difference that would please in the room the economists as well as those who care about patient care and patient outcome. In other words, we can improve quality of care and make it potentially cheaper. So e-health really has a lot of exciting potential, but we need to capitalize on it. So a project that connects us both is called eHealth Innovation, and it's really a rather humble project about building a roadmap and connecting across Europe where is innovation taking place around patient-centered care, and that does include in this neck of the woods. So Ian has provided us case studies of things that are happening here, and we're trying to identify common success factors across multiple stakeholder groups, and then to influence both the Commission and European ministries and regions so that they should promote those success factors and have strategies for overcoming relevant barriers. So it's an important but very, very small funded project about trying to scale up person-centered care. What we also need to do, and what the Commission is really very keen to do, is to respond to the problems that are called the ageing society. And the European Commission's initiative is called Active and Healthy Aging. And it's really about altering the landscape, which on this slide at the moment looks pessimistic, that we are expecting a doubling of those who are aged 80 plus by 2025. And I haven't worked out if I'll be in that group, but don't let me do the maths. We're going to be changing the ratio of people who can deliver and support economically and in terms of healthcare workforce, those who need help and support, going from 4:1 to 2:1. So we've got some very serious challenges to consider, but what the Commission is very keen for us to do is to not wallow in self-pity that Europe is going down the tubes, but rather how can we use innovations like eHealth to transform our patient population from a kind of burden to an asset, which again is about how can we bring patients into the active space of being players in their own healthcare. How can we shift historic approaches to healthcare from reactive, disease treatment-centric to preventive, disease-preventing, function-improving services? It's quite nice when thinking about this to consider the individual as being on one or more points along a spectrum. And this is where we need, again, a rethinking. We've tended to place the emphasis of healthcare spending and healthcare services, even training, on the areas that are marked in red under the professional range. And that means kind of the professional autonomy range. Whereas what we need to do, to use a phrase that Ian's already used, co-production, is where we partner individuals and work with them on staying much more strongly towards the left-hand end of this spectrum. So that's, again, a way of describing the shift of healthcare that we need to do. eHealth is very well placed to do that. Do we have the evidence base for it? Well, I think Ian's starting talk would suggest that we're really only scratching the surface of the evidence to help us make that shift. So one of the things HeRC can do is help us with that evidence base. Ian, I've got a number of slides from different people, but it felt appropriate that I should pinch some of yours too. So this is one of your slides. And I may not say the same things you do to the slides that I steal, but that's my prerogative, I think. Co-production of health leads us also to a richer record, because we start to capture increasingly the things that patients and citizens want to record about their health, their expectations, their experience of health and illness, as opposed to those that the medical model filters us to document. So what I see on the left-hand side is an enrichment of the information heritage that we can use. And what I feel I'm seeing on the right is that by having these large repositories increasingly networked at a national or even European level, the ability to have much finer-grained understanding of individuals. And it is a personal crusade of mine to go further than one of the panelists said. I want to ban the word phenotype. I think the word phenotype is an insult to individuals, personally, as an ex-general practitioner. And I would love us to start thinking about individuals with personal health patterns and very, very small groups and clusters that allow us to become increasingly refined in how we understand health, illness, and treatment effectiveness. And that's, to some extent, a link very nicely into the potential opportunities with molecular medicine, genomics, which are also giving us very, very fine-grained particular information about individuals. And my hope is that we can use that combination of co-produced health records, person-centered care, focusing on the individual in the services, and focusing on the individual and very small groups in the science, to come together to enable us to sharpen what medicine does. And in that sense, I am totally with the individual who's, sorry, I can't see you from scanning the audience, who wants to sort of ban asthma as a generic bucket, because I think that is the way we need to go. If we are going to leverage health records to have that kind of intelligence, we have to have a much richer join between the information in records and the medical knowledge environment, and then be able to achieve many of those representations of knowledge that deliver healthcare and deliver research that are in the green. So one of the other challenges that we are joining forces with, and in fact I also join forces in this with Bediran, is interoperability. It's an important challenge, and I'd like to just mention now a project called Semantic Health Net, which is a network of excellence. Again, not massive budget, as you can see, but a very important international as well as European player in trying to bring together the different standards and formalisms used to represent health information so that we can join together, create a greater semantic harmony in how information is represented. If we don't do this, we cannot safely interpret data coming from heterogeneous systems and heterogeneous environments. This is definitely a problem facing healthcare and joined-up healthcare. It's also a problem facing clinical research. Just take a look at this slide. I'm not going to read all this out, and I hope you can just about read the small print at the back. If you just think about doing a query and sucking out a diagnostic code for chronic obstructive pulmonary disease from the record, and you could just suck it out on its own, just think how easily you could misinterpret what that means unless you are aware of all of the many different kinds of scenario that might give rise to it going in. And some of that context information might be in surrounding other codes that you didn't suck, might be in the templates and the screens that gave some context, might be in surrounding free text. Unless we take care about the semantics of what's in electronic health records, as we move to higher resolution population health and electronic record analyses, we're going to go further and further into a smokescreen of misinterpreting the data we're querying. It'll look fine, but it won't be fine if you ever look down inside and looked at the data you were querying. So part of what we want to do is to move to a stage where this kind of context, every one of those representations is potentially computationally understood, distinctive, and interoperable across systems across Europe. We have a headache to try and help us achieve that. And this is why we need a project like Semantic Health Net. This is why we need great brains like Ian and Bediran to help us. It's because what we've done over the last years is assemble a whole series of informatics standards and specifications that are bewildering, partly because there are so many, and partly because almost every one of the line items on this slide was developed in isolation from every one of the other line items on this slide. So there's almost no coherence, sadly, across the informatics standards and specification landscape. Please don't try and read all the small print. All I want you to do is to feel there's a lot out there, and this is just the subset I could think of. So we have a frightening job on our hands to try to bring these things together. And we have to bring them together to solve Ian's problem. So this is the second of your slides, Ian. In order to achieve the coherence that Ian has clearly articulated a few hours ago, we need these care pathways to be capable of being interpreted together, compared, so that things can be streamlined temporally, things that might interfere with each other can be recognized. Unless we have that semantic coherence, we're just not going to get anywhere. And yet we know that with our aging society, the biggest next generation challenge for us is multi-morbidity. It's not single disease anymore. Those days are gone as a problem. It's multimorbidity, and we are nowhere near being equipped in health informatics to cope with multimorbidity. That's a shame on us, but we're now trying to fix that. And then when we've solved those problems, we're now trying to say, can we use electronic records to help us to discover new knowledge? So first of all, clinical trials. We had a very nice presentation from Paula earlier today where she articulated a number of the problems with clinical trials. I had a couple of numbers here. 50% of trials today failing to recruit their target numbers. And studies showing that if you do use electronic systems to try and identify patients to invite for trials screening, you are much more likely to find relevant patients. So the project I'd like to tell you about, again, partners together in crime on this one, Ian, is HeRC. It's a huge project with a very large number of pharma as well as academic and hospital partners all over Europe. And the project is basically building a generic platform, an integrating environment that will be able to send queries into disparate electronic health record systems across Europe, starting with clinical data warehouses that many hospitals have rather than their operational EHR, in order to help pharma who wish to conduct studies to refine their protocols so that they can adjust the inclusion and exclusion criteria, which you saw very nicely presented in the Farsight screen earlier today. How do we tailor those to get it right? If you remember the Farsight screen, this is basically Farsight to a European specification. And Farsight is indeed a relevant input to this project. Then, once we've got the query right, how do we identify and recruit appropriate patients? And then once patients are in a trial, how can their cumulative health record and their clinical research record appropriately cross-fertilize? So those kind of things, there's a lot of duplication currently. Many research projects do great things in the years for which they're funded and then fall off the end of a cliff. How many of you can actually hand on heart say, you haven't had that experience? We've all had that experience. So a large part of HeRC is business modeling. And again, I'd have to say that Ian's colleagues and my own are very active in the business modeling dimension of this. Again, bringing experience from this part of the world into the business dimension. How can we build a sustainable entity that will take forward the platform, its specifications, engage with a pluralistic multi-vendor environment? This is not about saying we will build the only one on the planet that will ever exist and the vendors go away and cry. This is about saying we're building a proof of concept, we're building a first instance, we want to welcome industry to come in and build others so that this scales across Europe and preferably scales transatlantically. I was in Boston last week with some of these very slides, not most of them I should say. Most of them were new for today, but a few of them from last week, and the US is really excited by this. They don't have anything of this scale and sophistication. We need it to sustain, and there are lots of benefits. I'm going to skip the slide in the interest of time, but maybe you could just read the first one, the first bullet. We want to improve mechanisms for patients to be included in trials, whether this is through hospital-based recruitment or eventually patient-direct involvement in trials recruitment. And obviously, if we can shave 3 to 6 months, maybe 9 months off a trial, we are accelerating that drug reaching to market. And that's quite an important thing for patient benefit. The final of the 4 projects I want to briefly speak about is another one that has probably the closest synergy to what the HeRCs are trying to do, and it's even bigger, with even more partners. It only started a few months ago. We're still sort of just about getting over the shock of being funded and remembering that we've got deliverables coming up. You know, that panic stage where you've actually got to do something. We're just about at that stage. It's absolutely massive, and its vision is to conduct novel research on an unprecedented scale. So across the consortium, which is as large as the previous slide you saw, the number of those consortium partners are data sources. And between them, That's 40 million patients sitting inside repositories that we could access, bringing together clinical and omics data, helping to develop a secure platform. And the work that we are involved in from our side is the horizontal mustard color layer, which is to develop a generic set of platforms and tools to integrate data, partnering initially to disease verticals with other consortium partners in Alzheimer's disease and metabolic disease. And the intention is that over time, more disease verticals will get added and our platform will get enriched. So that's a really exciting project. The vision of this project, and I'll just quickly build on this one, is that we're starting with cohorts of data. We're linking these cohorts to electronic health records to enrich the data inside those cohorts. We end up with richer data sources. And then from that, we're able to identify large populations, cross-cohort populations, from whom we can then conduct new queries, new research, and develop new insights. Now, if you feel a pattern recognition with HeRC, I'm delighted, because I think there's a lot in common. Last two slides, Ian, am I right? I'm just running about a minute over time. I'm sorry for that. I just wanted to share with you an excitement from Gartner, because Gartner's rather excited, not about HeRC. I'm sorry to say, they haven't picked up on HeRCs yet, but excited about where we're going in the health ICT landscape. They see this generation as now arriving at a nexus of four forces. The social capabilities of ICT, bringing together physical and virtual spaces. The mobility, allowing ICT in healthcare, in health, in prevention and wellness, to be increasingly pervasive, knowing when and where to interrupt us, so being context sensitive. So I don't get a phone call now, but I would in the coffee break. That kind of cleverness. Being able to harness not just cloud storage, but can we move HPC into clouds so that we really do deliver distributed high-performance querying, obviously feeding in very, very big data, but perhaps also discovering through this knowledge we didn't even look for. So can we go beyond hypothesis generation even to serendipitous discovery? That's their vision. It sounds very exciting. I'd like to close by just saying that I believe that the opportunity we have here between Manchester and London is that we are involved in a lot of areas of work at a European level that we would love to bring in to the HeRC environment so that Europe helps support and helps us to support and learn us in what we're doing in the HeRCs. But obviously, a reciprocal relationship. We would love to see the HeRCs at some point being able to offer back at a European level the things that we learn. So I hope we have a lot of fun, both in the UK and at a European level. Ian, thanks.